everyone, and welcome to Frankly Speaking About Cancer, Chronic Blood Cancers. I'm Kelly Kraft, Program Manager at Gilda's Club Quad Cities. Before we get started, I just want to give a little background about what Gilda's Club does. So we are a cancer support community that provides 100% free cancer psychosocial support to the entire family. So that's the person with the diagnosis, the person who is maybe past treatment, the survivors, that's the friends and family, that's the kids and teens, so anyone impacted. And we do that with our programs like support groups for anyone impacted by cancer. We have educational workshops like this one, healthy lifestyle activities like yoga and meditation. We have our social programs, and we're also a hub for resources and referrals. So I will let the doctor take it over, and then I'll be back in a little bit with you.
All right.
I gotta click a button. Got it. Perfect. Oh, and a couple of workshop disclosures real quick here. Of course, now it stops working.
I can do it.
Can you hit next on that?
It's not.
You might have to do it this way where we click down here. There we go.
Okay.
So just a couple of workshop disclosures here. And then our overview.
And so as introductions, my name is Susanna Freeman. I'm a physician, owner of Iowa Cancer Specialists in Davenport. And I will be talking about the chronic leukemias. Does everybody know what a leukemia is? A leukemia is a cancer of the white blood cell. In our circulating blood cells, we have red blood cells that carry oxygen from the lung to the body. Platelets stop bleeding. They're not really cells, but they're shed from cells. And then the white blood cells are part of our immune system and then fight off bacterial invaders. So if the white blood cell, if one of them becomes cancerous, it can lead to one of these conditions: chronic lymphocytic leukemia and chronic myeloid leukemia. So that's what we're going to be talking about. Yeah, so cancer doesn't define you. I feel like the best thing for a patient to do is to learn as much as they can about malignancy, if it's involving them or a family member, because that's kind of, you get through the fear and of the unknown, and the more education you have. So always look for support and education. So we're going to talk about what is CLL, which stands for chronic lymphocytic leukemia. The SLL part is that anytime you have a cancer of the white blood cells, since the white blood cells travel through your blood vessels, they also travel through your lymphatic system, which is like right next to your blood vessels, and it's like the waste removal system of the body. You don't really hear as much about it as you do with arteries and veins, but it's also lymphatic, so it's all arteries and veins. And so SLL just means that these white blood cells are in the lymphatic system involving the lymph nodes that we can detect, but it's the same disease. So C is chronic. So there's also leukemias that are called acute leukemias. Those are more emergent. We need treatment. More commonly happen in children and younger adults, but can happen in older adults. They're less common in the chronic leukemias, but we're talking about chronic leukemia. So the CLL stands for chronic, meaning the evolution of disease can happen over months to years, usually many years. Lymphocytic means it involves the lymphocytes, which is a subtype of the white blood cell. Leukemia means cancer of white blood cell. We're also going to be talking about CML, which is chronic myeloid leukemia. So it's the same, it's similar to CLL, is much more common than CML, but they're both chronic leukemias that are very treatable, and patients can have long lives with both of those diagnoses. The acute lymphocytic leukemia and acute myeloid leukemia, those are not going to be discussing. That's a whole different subject, but they're also white blood cell cancers. And so I mentioned, so small lymphocytic lymphoma is basically on, what do you call it, CLL, and also the same disease. It's a spectrum. So CLL is white blood cells mainly that you detect in the bloodstream, and SLL is the same white blood cells. If you look under the microscope and look, but they're in the lymph nodes more than in the white cells, or in the bloodstream. And there can be overlap too. What is CLL? Does anyone know what CLL is or have any? CLL is chronic lymphocytic leukemia. So it is a cancer of the white blood cells. So in the bone marrow, all of our circulating blood cells, the white cells, red cells, and platelets, they are born and they mature in the bone marrow, which is all the spongy central bones, and they're released into the blood system, and they circulate. So when a white blood cell does that, what happens is that it's able to mature and it's almost about to be released into the bloodstream. And then there's a mutation or something happens to the cell to where it makes too many of itself. And so that forms as a cancer of the white blood cell. But many times with CLL, it's not, when that happens, it doesn't cause any problems in the patient. And so if there's no problems in the patient, we don't necessarily have to jump in and do any sort of treatment and monitor it, which we'll probably discuss here shortly. There's currently no cure for CLL. That's probably changing soon. That's like in evolution right now. But in general, it's a chronic disease that I have many patients that the majority don't need any treatment at all. We monitor, and those that do need treatment receive treatment usually for a short period of time and go off treatment and are monitored for however long, and they may need treatment again, they may not. So it's we treat it as a chronic disease. So does anybody not know what these words mean? So I can explain what they are. Anemia, chronic leukemia, lymphocytic, and marrow. Lymphocytic just means of white blood cells, there's lymphocytes and myelocytes. They're two different, so it's just a subtype of the white blood cell, which is where CLL, that's where the cancer originates from. Marrow is bone marrow, that's the spongy part of the central bones of your body. Anemia is low hemoglobin or low red cell count. Chronic, it's not acute. Leukemia is cancer of white blood cells. Or I'm sorry, blood cells in general. There are some cancers of red cells and platelets, those are much rarer, but in general, most leukemias are white cells. So CLL, chronic lymphocytic leukemia, is the most common type of leukemia in adults. And we see quite a bit of it, and most of the patients that I follow with CLL, we just monitor. There's, a good minority that we do have on active treatment intermittently, but the majority of patients with CLL do not need treatment. 21,000 new cases per year, and the average age of diagnosis is around 70. I've never seen anyone at the age of 70 or kids with CLL. I'm trying to think of the youngest patient I've seen with CLL, but I want to say it's 50, 60. Yeah, definitely not in the 40s, but I'm sure that happens, it's rare. So most patients with CLL don't have symptoms, and so the whole rationale behind treating CLL is to relieve symptoms or problems with CLL. So since the majority of patients don't have symptoms, majority don't need treatment. So the symptoms of CLL that we consider to possibly treat if they occur are unintentional weight loss, drenching night sweats. You have to wake up multiple times and change your clothes, change your sheets, spiking fevers causing symptoms without proof of infection, low blood counts. If the CLL cells crowd out the bone marrow, the red cells and the platelets can't be produced properly, and they can be low. And so these are all potential symptoms or problems with CLL, which you would discuss treatment options. But a majority of patients don't have any symptoms and don't need treatment. So the way we usually diagnose CLL is we'll see an elevated lymphocyte count. So there's a neutrophil. So when you have white blood cells, there's the neutrophils and the lymphocytes, so the two main types of white blood cells. So we're talking about lymphocytes. And so if the lymphocyte count is high, then we look under the microscope. If it looks suspicious, we'll send it for a special test called flow cytometry, which is at a lab where they look at the proteins on the surface of the white blood cells to determine are they normal protein expression, or are there some abnormal proteins or lack of proteins that are commonly seen in CLL, and are there multiple cells of the same, from the same cell, which is what cancer is. So we send that, and that's how we diagnose it. We usually don't have to do a bone marrow biopsy, which we do for many other hematologic malignancies. So CML, so we just talked about chronic lymphocytic leukemia, the most common chronic leukemia or leukemia in general in adults. CML is also a chronic leukemia, so it's the same idea. The cell is not acute. You don't have to immediately be treated. It's something that comes on, slowly, chronically. But the only difference is that the cell involved that becomes cancerous isn't the lymphocyte, it's the myelocyte. And so it's also blood cancer, starts in the bone marrow. So CML it was one of the first diseases that was found to have a specific genetic alteration that was targetable by an oral medication. And I remember writing about this in my med school essay. That's how long ago it was. But it was like, oh, this is, CML is blah, 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 blah. But and it was called imatinib or Gleevec, and it's still used today in a lot of patients with, first-line CML treatment. But the medication is a pill, and it's a small molecule inhibitor. It inhibits, or it blocks this genetic mutation that happens in the cells. It causes the cancer, so that those cells can't, survive, and the normal cells can proliferate. And many patients who have CML, we don't say they're cured. Some are, but a majority of, if you're on this oral medication for a long period of time, indefinitely, most patients stay in remission. About 50% can come off medicine. We say after 2 years of being in molecular remission, we can't detect anything. We can give you a trial if you want off the medicine. About 50% can continue with off medicine. So, but it's a disease that was one of the first ones that before the advent of knowing this mutation and medication, patients with this disease their life expectancy was on the order of years, and now they're almost normal. BCR-ABL stands for, I think, breakpoint cluster rearrangement. I forget. But anyway, it's a genetic abnormality where it's a translocation where one part of a chromosome and another part of the chromosome 9 and 22, they do a translocation, a genetic switch, and that leads to these white blood cells just proliferating too much and forming a leukemia, too many white blood cells. Blasts are what we call early leukemia cells. So when a white blood cell is born in the bone marrow, it's a blast. That's like the baby cell. And then it matures, it gets smaller, smaller until it becomes a mature white blood cell released into the bloodstream. So blast just means that's a sign of acute leukemia. They're normal, 1% in the bone marrow, but if you see a whole lot of them, or you never see them in the peripheral blood, that indicates acute leukemia. Philadelphia chromosome is another name for the BCR-ABL translocation. I don't remember why they call it that. Yeah, so now with the advent of, everyone checks blood work once a year or whatever, many patients are diagnosed incidentally. So I get lots of referrals for elevated white cell count. Vast majority are from smoking. So cigarette smoking causes an elevated neutrophil count. So that's which is CML or, elevated increase in neutrophils. So that's something that's on the differential. But usually with CML, if you look on the blood smear, we get blood from someone, we put on a smear, I look under the microscope. CML, the cells are usually, so with smoking or a reactive cause of elevated white count, you just see mature neutrophils. With CML, you'll see mature neutrophils, but you'll also see some kind of immature neutrophils. It's a very, classical sort of look. So it's, when you look at the blood smear, it helps you determine whether you should look into, more testing for CML because it's expensive. It's, genetic testing to do this. But CML, if it's not caught incidentally on a blood test, I've seen patients where what happens is that the bone marrow gets completely full of the CML cells. So the bone marrow can't make the normal white cells, red cells, and platelets. So what happens is the spleen and liver take over and they start making blood cells because they did when you were an embryo and then they stopped and bone marrow does it. So but they can take over again, they can make blood cells. And so patients get very big spleens and livers, especially spleens, and that can press on their stomachs. So they lose weight, they don't want to eat, and then they're tired and they don't feel well. So they can be very symptomatic. And I've seen both ways. I've seen patients come in with an incidental elevated white count, they didn't know symptoms yet. And then other patients come with huge spleens, lose weight, nobody knows what's going on, fevers. So anyway. So diagnosing, the main thing is looking at the blood smear. And if there's any suspicion at all, there's an easy molecular test for this BCR-ABL Philadelphia chromosome that you can test for. Majority of patients are diagnosed in chronic phase. That means that there is an abnormal clone of these white blood cells in the bone marrow, but it's not, they're sort of stable. Versus accelerator blast crisis means that these cells, so CML means chronic, so it means that the cell that has turned into a cancer cell has already sort of matured, it's about to be released into the bloodstream, so it's sort of a mature cell. Accelerated blast crisis means that the cancer cell kind of, I forget the word for it, but the cell becomes less mature to where the cells look more like they're immature or just born, or they're maturing, and that's not good. That's a sign that everything is, usually a sign that you need to like look into a bone marrow transplant. There's a lot of more advanced treatments other than just the oral medications I mentioned. And so I mentioned that the first one was Gleevec or imatinib. There's actually multiple more now. There's, I think, 1, 2, 3, 4, I want to say 5 or 6 additional ones. And I have one patient who's been through all of them. This has had a different side effect for all of them, but they're all very effective. Communicate your healthcare team. Obviously, communication is important. These cancers are uncommon diseases. I'm sure that most of you have looked on the internet and have seen there's tons of places on the internet to look for things, right? And so I would definitely encourage you to do that. And then if you have any questions, write them down and then take them in to the physician. I have a lot of patients that come in and you can tell they're just sort of flustered and they didn't write anything down and they just don't know what's going on because they just got their lab results. And so it's helpful, if you can at all, to write any questions down you have when you go in and talk to your physicians. And then also, you should always feel comfortable calling the office and talking to, you should always be able to get a nurse to call you the same day for any issues you have. Yeah, so treatment planning is when your physician sits down with you and says, you know, this is the diagnosis we got from either, you know, the blood smear, the bone marrow, or the special testing. So what treatment options are there? Depending on your age and other medical conditions and the sort of phase of your disease, you know, there's the options of, depending on your CML or CLL, there's tons of options. With CLL, there's the big option is just do nothing and watch. With CML, there's really, we don't do that unless there's a contraindication to every treatment, which I have not come across. So with CML, it's so treatable with an oral medication. We always recommend starting, they're called tyrosine kinase inhibitors, TKIs. We recommend those. But there's option, you know, it's always good to talk about options. There's never just one treatment option. And these are, you know, one thing that, and I'll admit, we're not good at asking about is how does this affect your work, your school, your children's school, you know, whatever you do in your community. And those are the things that we appreciate if you bring up to us, because we can definitely help in all kinds of ways. But sometimes we're so busy, you know, focusing on the treatment and the planning and all of this, but we have all of the, you know, options, and we should be better at bringing that up to patients, but you should bring it up if there's any issues that you have. Second opinions are always good. They never hurt our feelings. It's just having more eyes on your case. And I think there's never a downside to a second opinion. And the only downside is that it could delay starting treatment, but it's rare there's a situation where delaying it by a week or two for a second opinion is really gonna make a huge difference. Sometimes it does, and in that case, we start treatment, but we call this, you know, we work with the facility that they're going to go to just to say, hey, we think they need treatment right away, and they say, okay, and we'll see about that. In general, so second opinions are a good thing. And these are just an example of questions, as I mentioned, not these specific ones, but anything that just have like a notebook, anything jumps in your head, just write it down. It's very helpful when I have patients that come in and they have all their questions written down, they ask, and a lot of times I'll come in and do my spiel or talk to them and stuff, and they're like, oh, you answered my question. But it's always good that I can't always do that. And so oftentimes there's ones that say, oh, you know, something I didn't think about. And it's really helpful for us to get your input and questions help with that. And this is just more examples of questions that you can ask. There's a lot of them. So treatments for CLL, as I already mentioned, most patients, this is chronic lymphocytic leukemia, average age 70, 71. Most patients don't need treatment because they have no symptoms or issues or problems from the abnormal flow of white blood cells that are growing in their bone marrow. It's not crowding out the bone marrow. It's not causing any issues, problems. So we just watch them. And so if it's someone we're just seeing, we'll say, we'll see you in 3 months and 4 months, 6 months, a year, and then once a year thereafter, and we tell them when to call us. You know, if you have unintentional weight loss, drenching night sweats, fevers, or just anything, you know, in large lymph nodes, can't eat. But otherwise, then we see these patients once a year. But you know, after we establish a case of disease, when you're first diagnosing them, you just want to make sure it's not going to be an aggressive CLL, because those do exist. So we do see them frequently the first 1 or 2 years, but after that, it's usually just once a year. And so that's called watch and wait. And I haven't, so I guess, I mean, there's the question of, well, I feel like I have this disease and I'm not being treated, isn't that bad? Well, I'll tell you that not almost all of the treatments for CLL can have potential consequences. So if your current CLL isn't causing you any side effects or consequences, there's no reason to do a treatment that's going to cause problems, side effects, consequences. That doesn't make sense. And then we have some patients that they want to be seen every 3 months, or which is fine, every 4 months, because they're anxious about, they have this cancer and nothing's being done about it, even with all the things we tell them when to call it, so we just see them more frequently. So when to treat, I kind of already mentioned it's individualized. Some people might have some fevers and doesn't bother them, but it's unintentional weight loss. The drenching night sweats is an issue. People, they get up and they have to change their clothes, their sheets. It's annoying. You know, they lose sleep. That's a big thing. Fatigue, enlarging spleen, which can pressure on the stomach and impact ability to eat. And then enlarging lymph nodes, and I'll tell you, men with enlarging lymph nodes don't care, and women do. And so we generally end up treating women with enlarging lymph nodes from CLL in the neck because they don't like how it looks, and men usually don't care, just in general. So that's why I'm saying it's individualized. But there's no absolute reason to treat just for enlarged lymph nodes unless somebody doesn't like how they look and wants them to shrink them, because there are side effects and problems with the systemic treatments we have for CLL. Yeah, and so the goals of treatment are, again, this cannot be cured. However, it can be put in a remission for a very long time. I have many patients that we treated and then like 4 or 5 years to treat again briefly, and now they're on observation. And some patients I've treated and have not had a recurrence. So it's just completely, there's a wide variety of how this, like it says, most people are treated on and off for years. So it's sort of a chronic disease we treat. Currently no cure. There's lots of different treatments for CLL. I guess it used to just be chemotherapy, and now we have what we call targeted therapy. I think we're going to talk about it here in a minute, but they're called BCL2 inhibitors, the new oral medication called venetoclax that targets BCL2 protein on the surface of the CLL cells. There's also IV medications or antibodies that target, it's called CD20. It's a protein on the surface of the CLL white blood cells, and that's added to chemotherapy to target the cells to kill them. There's also a class of medicines called rutin tyrosine kinase inhibitors, or BTK inhibitors, and there's oral medications that are also indicated for treatment here. So there's lots of different treatments, and that's why sometimes, if it's overwhelming, it's a good idea to it doesn't, to get a second opinion, get more information, etc. Can you recommend second opinions? Usually if we have a second opinion, we offer University of Iowa, which is 45 minutes away or 50 minutes away, Mayo, Cancer Treatment Centers, and Northwestern in Chicago. It's sort of the closest is University of Iowa. So we just sort of say, it's sometimes up to their insurance who they can see, but so whatever they want to do, we do referrals, and we communicate with, all of the physicians at those institutions. I think I already talked about that. I guess one thing, so if you're diagnosed with CLL, initially we do some genetic analysis to see if you have a specific mutation, which is the 17p deletion. That is a mutation in a protein called TP53. It is one of the most common mutations across all cancer types, and it usually portends a bad prognosis. And so that's something that we do look at, because if that is positive, you have a mutation that informs like what our initial treatment is if you do need treatment. Chemoimmunotherapy, I just mentioned chemo. If we do give chemotherapy, it's combined with the CD20 focusing molecule that's called immunotherapy. So these are usually not used anymore. So initially, so now we have our targeted agents, but chemoimmunotherapy, I guess in some cases are used. FCR is just a straight chemotherapy combination as a chlorambucil that might be used in someone elderly, can't tolerate anything else. Bendamustine. Rituximab is a CD20 focusing antibody. But in general with CLL, we don't use these anymore because now we have these targeted therapies. The ibrutinib is the Bruton's tyrosine kinase inhibitor. Acalabrutinib is another medicine in the same class. Idelalisib is actually in a different class that we don't even need yet because we have ibrutinib and venetoclax, and we never have to get to that third line, at least I haven't yet. Venetoclax is at the bottom. That's a big, so we have lots of, these are all oral, the ibrutinib and venetoclax are oral medications. So we don't really, at least I don't use chemotherapy for CLL anymore. Immunotherapy is basically it's a monoclonal antibody. An antibody is a substance that can recognize a certain epitope or a certain protein or something. And so these rituximab is an antibody that recognizes CD20. CD stands for cluster determinant. That's how they describe the proteins on the surface of white blood cells. It's like CD20, CD79, CD, whatever. There's tons of them, but CD20 is the one that rituximab targets on the surface of white blood cells. Stem cell transplant for CLL, I've not seen it done. That would be someone who's really young, who goes through tons of regimens and doesn't get any response. And same for CML. CML, now that we have the tyrosine kinase inhibitors like imatinib, et cetera, they usually the stem cell transplants are needed. Stem cell transplants are when you obliterate your own bone marrow, which makes all your circulating red cells, white cells, platelets, and then you either infuse your own bone marrow that's been collected earlier that doesn't have, or hopefully doesn't have any of the cancer cells in it, or somebody else's bone marrow, like a donor. But again, for these two diseases, these are almost, I can't remember a case where a stem cell transplant was used in the past 5-10 years. CML. So I mentioned, so targeted therapy CML are these, they're called tyrosine kinase inhibitors, or small molecules that targeted therapy to this abnormal, the BCR-ABL mutation causes an abnormality in the tyrosine kinase that this blocks. Imatinib, Gleevec was the original one, but there's multiple other ones. There's actually another one, I forget what it's called, but since ponatinib, there's been actually an additional one that's released. And they're oral, you take them by mouth. Yeah, so as with most medications that we use for treatment of cancer, it's really important to double check with your pharmacist. Does food interact? Can you take it with food? Can you take it without food? There's a huge, some, and I can't remember them all, we have to look them up. But yeah, some medicines we take with food or without food doesn't matter, some can't. Some you shouldn't take like around when you take a proton pump inhibitor. There's a huge list of things, so definitely something you want to talk to your pharmacist about to make sure there's not going to be interactions. I mentioned a stem cell transplant that it says some patients may require allogeneic stem cell transplant. That would be someone who's young who fails all 5 or 6 of the TKIs, but again, that's not really used now. So chemotherapy, I guess I've been hearing about CML. So when we talk about chemotherapy, it's a non-specific medication that kills rapidly dividing cells. So since cancer cells divide more rapidly than normal cells, that's why the cancer cells are preferentially killed. However, that's also why you have these side effects to the normal cells. Cells that rapidly divide are the cells that line your hair follicles. That's why you can lose your hair. Cells that line your gastrointestinal tract. That's why you can have nausea, vomiting, ulcers, diarrhea, all kinds of problems there. The cells in your bone marrow rapidly divide that make your circulating white cells, red cells, platelets, and that's why you have low blood counts. And that's usually why you have to wait with chemotherapy cycles, wait 2 or 3 weeks until your next one because you want your bone marrow to recover. Hair and nails. So I already mentioned the hair, but chemotherapy you can affect any dividing cell in your body. Immunotherapy is a more targeted therapy. And I guess what they're talking about here is that patients that can't take the oral tyrosine kinase inhibitors for whatever reason, there are some immune modulating therapies that were initially used before the TKIs, imatinib, were introduced. So before any TKIs were available, the treatment was interferon, which interferon it's made in the lab and infused, but your body makes interferon, and it makes interferon when you have like a viral infection or you're sick. Interferon stimulates your immune system, but it also makes you feel horrible. And so interferon, nobody likes it because it makes you feel bad and stimulate depression. But it is an option if you cannot have, if you fail or, aren't responding to the TKIs, but that's uncommon. And the monitoring is we actually monitor for this BCR-ABL rearrangement. There's ways to monitor for it at different ways. There's a FISH, there's called PCR, polymerase chain reaction. That's the most sensitive test that we use. So it's easy to confirm somebody is in a remission and responding to your TKI. You don't have to do bone marrows every year or anything like that nowadays. Clinical trials are always good, especially if you don't respond to a first treatment for a condition, and always looking into clinical. So most clinical trials look at the standard of care versus standard of care plus something added to it. So that's the majority of the phase 3 clinical trials. So it's usually the reason why it's in a phase 3 clinical trial is because it passed an earlier phase 2 clinical trial which showed some benefit. So we do encourage clinical trial participation if available. Yeah, so there's clinicaltrials.gov is a good website. And most clinics have like a clinical trials nurse who can provide information and look things up, or at least refer you to where you can have that done. Side effects. So everybody reacts differently to side effects, and as I mentioned, side effects, especially from chemotherapy agents, can affect literally any part of your body. And so you might be asked about something. The best thing is for you to volunteer if there's something new or that wasn't asked about, because unfortunately we try, but we can't. We don't ask about every single thing. So if there's something that's new or new side effect that's happening with you or something you're worried about, definitely you want to tell your provider about that. To make sure they're aware of it, because there's probably something that can be done to alleviate the side effect if it's being caused by the treatment now. Fatigue is very, very common. One thing I tell patients is that aerobic exercise 3 times a week in the morning for at least 15-20 minutes, that means your heart rate's up and you're huffing and puffing. That will get your endorphins up. It helps you with fatigue. We strongly recommend that. Yeah, so CLL patients do have a higher risk of infection. And so patients that have upper respiratory infections that don't, like sinus infections, bronchitis, ear infections, that don't get better with, one course of antibiotics, et cetera, or they just persist. Many times, if they have a low immunoglobulin level, we can actually replace their immunoglobulins or antibodies. They don't have enough to fight infection. We can actually replace those with a blood transfusion of pooled other patients' antibodies. It's called IVIG. And this is just some side effects and tips for diarrhea and constipation. So basically anything that might be an irritant to your GI tract, which is caffeine, eat a spicy food, and you can just sort of picture, think of what's irritant. Don't drink that. Drink lots of water. And then if you do have loose stool, oftentimes there are medications that can be prescribed that will control diarrhea that you might have to take on a chronic basis, but that will prevent it. It's disturbing you. Constipation, many medications can contribute to constipation, but there's other things you can do to help with that. But staying active helps across the board. Pain. So a lot of times pain with treatment of CLL and CML relate to the effect of treatments on the bone marrow. A lot of patients feel like bone marrow pain, like a deep pain. And so there are some treatments that can help for that. Antihistamines given several days before treatment can help prevent bone pain. There's a low dose dexamethasone, a steroid that can help. So there's things that can be done prophylactically to help prevent pain, or to, we can add in if you do experience pain. And insomnia is a huge problem, especially if you're getting steroids, which is a common part of regimens for treatment of these hematologic malignancies. They can cause insomnia, like prednisone, dexamethasone. So just the morning exercise is very helpful, and then avoid. Yeah, you definitely don't look at a screen when you go to bed and you listen to music, or have all the lights down. But there's things that if you have problems, ask your doctor to help you with that. Mouth sores, mucositis. This is a common issue. Depending on what's causing mucositis, there's lots of treatments for it. There's lots of it's called magic mouthwash, green goddess. There's lots of different formulations of 3 or 4 different soothing medications that you swish and either spit out or swallow that can help mucositis. There's also a steroid mouthwash that's recommended in certain regimens that have a high incidence of mucositis to help prevent it. There's something you just have to let your providers know about so that they can address that. Rashes, so skin toxicity is pretty common with the oral tyrosine kinase inhibitors like imatinib and things like that. It's definitely important to wear sunscreen and realize if you're like at a window or in a car that doesn't have UV protection, even though you're inside, you're still getting the UV. So you should always just put on sunscreen every day, wear a hat if you can, cover your skin outside, moisturize. So nausea and vomiting, it's really eating like a bland diet can be very helpful. But talk to your provider, because causes of nausea and vomiting, or they can be the chemotherapy effect on the central nervous system. There's also, you can have some blockage of the digestive system. So especially if you're throwing up, that's not normal. You should let your provider know to make sure there's no blockage. Kidney failure can cause nausea and vomiting. Central nervous system disease or increased pressure in the central nervous system, the brain, can cause nausea and vomiting. So it's not always just from the chemotherapy. It's important to let your providers know, and if there's anything that you're worried about. Low blood counts. I mentioned that's why we have to wait with chemotherapy usually to give different further cycles, because the bone marrow is affected. When you have a low platelet count, anything can bleed. So constipation, if you strain, if you have hemorrhoids, they can bleed. So you want to try to avoid that with stool softeners, etc. A soft toothbrush, or sometimes some patients with low, if you have any bleeding, we just say use like a soft cloth. And so you just want to be careful. The mucosa, which is in your mouth and the rectal anal area, that's very, with low platelets, it's easy to bleed in those areas. So anemia is a low red cell count, and since red cells carry oxygen from your lungs to the rest of your body, if you have an anemia, your body is basically starving of oxygen, and the symptoms are feeling tired, and different systems don't work as well because you have to ration the oxygen that your body has. So just stand up slowly, move a little bit more slowly. There are treatments if the anemia gets to a certain point. There's shots we can give, and we usually do evaluation to make sure you don't have iron deficiency, B12 deficiency, other common causes of anemia. So there's a lot of things that can be done with anemia, but sometimes you just can't get around it. It's just you have to rest more, and it's sort of like a new normal. And this is I guess, I don't know if they can get this from you guys.
I'll look for
these forms, but this is just like with writing it down. The more information we have, is the better that we can, give you resources and help you. Palliative care is basically an adjunct to our chemotherapy, our direct treatments of the CML and CLL. Palliative care focuses more on the symptoms of the disease that really can't be impacted by treating the disease, or not impacted enough. It's sort of the extra treatments of symptoms. And the whole goal is to just improve quality of life. And usually when we give treatments, you know, unless we're trying to cure someone and we know that they have a high probability of being cured, we will make them feel horrible and give them lots of stuff because we know we're going to cure, that the whole goal is cure. But someone who's getting treatment for a disease that is not curable, then all of our treatments, the goal is to provide treatment or at least stabilization of disease, but not impact quality of life in a negative manner. So palliative care is just another a provider that can get involved and focus on, you know, some of these issues. Hospice care is generally, it's overlaps with palliative care, but hospice care in general, if you go into hospice care, you are not allowed, or they don't pay for any active treatment for your cancer. So if you go on hospice care, then that means you're not getting more chemotherapy or radiation unless it's palliative and would improve your quality of life. CLL, so yeah, palliative treatments include transfusions. If they have a low platelet count or bleeding or anemia that's leading to symptoms, we can do blood transfusions. There's a condition with CLL called autoimmune hemolytic anemia, which is where your immune system destroys your body's own red blood cells, and that causes anemia. And it can actually be treated with high doses of steroids. So that's something that's a palliative treatment. It's easy to give, cheap, if there's anemia, you know, related to that. And then if there's any pain caused by the CLL, whether it's bone involvement or swollen spleen or lymph nodes, radiation, palliative radiation, focused radiation in that area can be helpful for relieving symptoms. Yeah, so end of treatment, so at the end of your journey. And I always tell patients, so let's say you're not going to be treated anymore and you want to do palliative care, hospice care. That doesn't mean you have to do it forever. I wouldn't say a lot, but definitely had patients who went on hospice care, got better, and they went off hospice and came back and we treated them and they, you know, so that's, I always tell patients, it's not like an all or none. If you change your mind or you start feeling better, you can always get off hospice and, you know, go back to what you're doing. But that most patients don't do that. Yeah, for CLL, again, most patients, after we watch them, we tell them what to watch out for, we see them once a year. And it's always any patient that we see for any kind of cancer, we always talk about the normal screening, you know, the skin cancer screening. CLL patients can have more aggressive skin cancers. So I tell patients, if you see anything on your skin, you don't want to just, you know, let it go. You want to have it seen right away because skin cancers can be more aggressive. And then if they have a smoking history, you want to do the low dose lung cancer screening CT annually. If they qualify, colon cancer screening, it's now recommended to start age 45. And then depending on, you know, men, women, prostate cancer and breast cancer screening and pap smears, pelvic exams. Yeah, go to visits. Yeah, keep your health insurance. Yeah, avoid smoking. A healthy weight. So one thing we say is, so with elevated weight, fat cells actually, at least for breast cancer, increase the, that's where conversion of precursors to estrogen happen. And so we feel like that patients with an elevated BMI have a higher incidence of recurrent breast cancer, or primary breast cancers because of that, or at least ER positive breast cancers because of that fact.
I think this is where I take
Yeah,
it.
okay.
All right, so just talking about a little bit of the mental health piece of things. So these are just some universal challenges for people living with any type of cancer. Got lots of hope and control, living with uncertainty and unwanted aloneness. But there are some more specific challenges for people with CLL and CML. So with CLL, you're dealing with that having a long-term uncurable cancer, but also periods of health in between treatment. So you might be dealing with those lingering effects like fatigue, but also while you're doing all that watch and wait, some people might forget that you have cancer and not remember that you're still dealing with this long-term cancer. So some things that you can do is remember that maybe you're going back to normal isn't a situation you'll be seeing, but figuring out what your new normal is. And that it's just really important to remember that people with CLL typically live long lives. And that it's a chronic disease that can be controlled over a long period of time. And then, of course, getting support, whatever that looks like for you. So it may be family and friends, it may be support groups like a Gilda's Club, even online support groups can really help some people. So just find out what that thing is for you to be able to get those emotions out. A couple other things is trying yoga and breathing, things like that. If that's something that feels foreign to you, Gilda's Club has yoga classes, we have meditation classes, things that can really help with that self-care piece. And also just talking to your family and friends and making sure that they understand what you're going through, because they may not be able to see your cancer and you may look normal to them. And so explaining what you're going through so that they can help understand. And then if you're feeling sad or depressed and it doesn't get better, make sure you talk to your doctor. So with CML, you might be on treatment for the rest of your life. And so just kind of that is a unique challenge in and of itself. And again, people might forget that you have cancer because again, it's that long-term chronic illness instead of what, the public thinks of as cancer, that short-term acute curative cancer. So, and with that fatigue that can come with CML and its treatments, just feeling isolated. So making sure that we're, looking for that and trying to combat it as much as we can. And so some of the things to do with CML are similar to CLL. So finding support, again, just whatever that looks like to you, everybody's different and what helps them cope. And trying to increase our energy levels as much as we can, trying to stay active, easier said than done, but doing the most that we can to keep a routine and, keep a good sleep schedule, things like that. And then think about what your friends and family and loved ones can do to help you. So usually when we see a new cancer diagnosis, friends and family want to help. They just don't sometimes know how. So if you think of a few things that somebody can do for you, you can maybe give them a couple of assignments and help them help you. So just some living with uncertainty in general. These are pretty general for anyone with any sort of cancer diagnosis. But be informed, be aware that you're going to have control over some things, but there are some things that you're not going to have control over. This is a big, easier said than done, but be aware of your fears and practice letting them go. Talking about those feelings, enjoying the present, and just making time for the things that you really care about. Another easier said than done, but work toward having a positive attitude. It can really help. And if you're having trouble staying positive, again, reaching out to the people you care about, support groups, things like that. Finding ways to relax and enjoy your time and exercise as much as is realistically possible. And again, control what you can and do your best to practice being able to let go of some of the things that you don't have control over. And these are just some legal tools to help with common concerns. Most of these are things that we should all have in place, regardless of cancer diagnosis. A living will is an advance directive, just kind of telling your doctors what kind of medical care you want or don't want if you can't speak for yourself. A durable power of attorney is your person who will make medical decisions for you if you can't make them yourself. Another thing that everybody should have, because you never know what could happen. And that person, it's a common misconception. That person doesn't have to be an attorney. It can be really anyone that you may want to make decisions for you, which there's a law that says who should be your next of kin or who should be the person to make your decisions, but it may not be the person that you want to make your decision. So if you put it on paper, you get the actual person that you want. The financial power of attorney makes those financial decisions for you if you can't. And then there's a do not resuscitate order. And in Iowa, that's the I-Post, and in Illinois, that's the Holtz. It sounds so scary, this do not resuscitate order, but really what it is you get to put on paper if you do or do not want to get resuscitated. You can check a big box and make sure that anybody who's treating you knows exactly what you do and don't want for those kind of heroic measures. And then a will designates who gets what in the event of your passing. And just some cancer support community resources. That number on the screen, that 888-793-9355 number, is our cancer helpline, staffed by mental health professionals and resource specialists. nationwide can really help if you're running into a roadblock, and especially if maybe we're not available or we run into a roadblock, that's just another option for you. And then open to options, I could talk about open to options all day. It's a treatment decision counseling program where you sit one-on-one with one of our social workers if you are facing a fork in the road in your treatment. So it could be that you're about to start treatment and you're choosing between A and B with these side effects and treatment C with these side effects, and you have to think of the different, positives and negatives and come up with lists of a list of questions to ask your doctor. So you can sit down with one of our social workers, really get out the situation, your options, your goals, both treatment and otherwise, and leave that appointment with a list of questions for your doctor that, in theory, if you get all the answers to these questions, you have the tools you need to make your decision. It won't make the decision for you, but it should give you the tools you need to make the decision. And frankly, speaking about cancer is what we're sitting in right now. So keep an eye out on our calendar. These change every month, what we're offering. And I want to touch on base a little bit about our grassroots movement. It's that big scary word, advocacy. We all want to make a difference in the world, and sometimes it seems scary and big to try and do that, but there are little things that we can do, and there are absolutely big things we can do. And if you're interested and don't know where to start, or just want to connect to others who are also wanting to be advocates, the link is on the bottom here. And My Lifeline is just another tool out there for everyone. It's a live blog that you can update your loved ones about your cancer diagnosis, your what's going on day to day, give them updates so you don't have to call, every person in your contact list. There are also discussion boards where you can connect with people all over the world with a similar type of cancer. It also has a helping calendar, which is my favorite part of it. Maybe you're having a new treatment or a surgery or whatever it may be, and you know that you're not going to be able to cook meals for yourself for a little bit or for your family, or you need help getting to and from your appointments. You can go on My Lifeline and set up a helping calendar, like, hey, I need transportation to my doctor's appointment this day. I need maybe a casserole dropped off at my house this day, and people can sign up for those needs. So again, when there's a cancer diagnosis, a lot of times people want to help, they really do, but they just don't know what to do. And when we say, when someone says, call me if you need anything, it's so hard to call that person up, but they really do want to help. So this can give them something to help you. And before we end the Facebook Live piece of this, Melody, are there any questions or comments on Facebook?
There are not.
All right, well, thanks everyone for joining. I will end the Facebook Live broadcast.